Today you are about to watch a video entitled Task Management Training for Recognition, Prioritization, and Decision-Making for the SRNA in Airway Obstruction during MAC anesthesia. At the completion of this video, the SRNA will be able to master the task management element of non-technical skills, such as recognition, prioritization, and decision-making. The SRNA will be able to distinguish whether the patient is in light sedation, moderate sedation, or deep sedation. The SRNA will be able to improve decision-making based on early detection of changes in patient saturation and end-tidal CO2. And lastly, the SRNA will be able to prioritize intervention necessary when airway obstruction develops during monitored anesthesia care or MAC anesthesia. Non-technical skills are defined as the cognitive, social, and personal resource skills that complement technical skills and contribute to safe and efficient task performance. The common non-technical skills that are important for safe operations in high-risk organizations such as anesthesia include situational awareness, teamwork, task management, and decision-making. This video simulation trainer intends to instruct the viewer on the skills of task management via examples of an airway obstruction during MAC anesthesia. Video-assisted simulation training improves anesthesia trainees' non-technical skills by demonstrating common anesthesia scenarios while applying relevant knowledge and crisis management skills. This enhances the trainees' encoding, storage, and retrieval of learned information. In order to prepare for MAC anesthetic, gather all the essential equipment. The basic airway management equipment for MAC anesthesia are source of oxygen, nasal cannula, face masks such as venti, rebreather, or non-rebreather mask, tongue blade, oral and nasal airways, ambu bag, suction, standard monitors including oxygen saturation, end-tidal CO2, EKG, respiratory monitor, and blood pressure. Always have an advanced airway equipment and semi-closed circuit ready. The definition provided serves as the reference that can be used as a guide and may be modified depending on the individual practice circumstances during MAC anesthesia. Referring to the table above, let's start with minimal sedation. Patient will show normal response to verbal stimuli such as spontaneously opening his or her eyes when calling the patient's name. Airway, spontaneous ventilation, and cardiac functions are unaffected. If a patient is moderately sedated, purposeful response to verbal and tactile stimulations can be noted. These includes illicit response when tapped on the shoulder. Airway requires no intervention. Spontaneous ventilation is adequate with stable cardiac function. When the patient is in deep sedation, responsiveness is purposeful to repeated or painful stimuli. For example, sternal rub or peripheral stimulation may be needed. Intervention to support the airway may be required with the use of oral or nasal airway or mask. Spontaneous ventilation initiated by the patient may be inadequate, but cardiac function is usually maintained. Recognizing airway obstruction. The features suggestive of airway obstruction includes partial obstruction or complete obstruction. If a patient is in partial obstruction, an added sound of labored breathing where air entry is diminished. Assess for use of accessory muscle during respiration, such as tracheal tugging, paradoxical chest movement, and abdominal seesawing movement. When a patient is in complete airway obstruction, there is an indicative complete absence of airway sounds. There will be a flat end-tidal CO2 waveform and declining SpO2 level. Note that a low saturation reflects inadequate oxygenation. Tachypnea and tachycardia reflects respiratory distress. In anticipation of airway obstruction, observe and ask the patient his best breathing position. Be aware that the patient may have to position himself for optimal airflow. The following patient scenario will be used to help familiarize you with the task management strategies involved in the proper management of airway obstruction during MAC anesthesia. These include recognizing the manifestations of airway obstruction, prioritizing your interventions, and making appropriate clinical decisions. Mr. Jones is a healthy 35-year-old male patient weighing 70 kilograms who is undergoing bilateral inguinal hernia repair under monitored anesthesia care or MAC. The patient is in the operating room, positioned supine on the OR table, and has received 2 milligrams of Versed and 50 mics of fentanyl. Mr. Jones appears drowsy and comfortable but is still responsive to verbal stimuli. His airway is unaffected and his vital signs are stable. The surgeon proceeds to inject local anesthetic and the patient grimaces and moves his right leg.
Injecting local. The patient needs to stay still.
Decision making. Patient is comfortable but surgical conditions require deeper sedation. Therefore, give extra sedation or pain medication. An additional 50 mics of fentanyl has been given and a propofol drip is infusing at 75 mics per kg per minute. The surgeon makes incision without much response from the patient. He is occasionally lightly snoring with dampening of entitled CO2 waveform.
Incision.
Recognition. Patient's responsiveness is purposeful to verbal and tactile stimulation. Lightly snoring, but no required airway intervention is needed at this time. He is adequately ventilating and maintaining cardiac function at this moment. Sedation level is providing optimal surgical conditions at this time. Your prioritization is to anticipate any needed airway intervention.
Mr. Jones, take a nice deep breath.
To limit the fluctuations of the entitled CO2 waveform, the appropriate decision making is to ask the patient to take a deep breath and or perform head tilt and chin lift.
Patient may feel this a little.
The surgeon is reaching the most stimulating part of the procedure. In anticipation, additional medications are administered. Mr. Jones has now received 150 mics of fentanyl, 3 milligrams of Versed, and the propofol infusion is now running at 150 mics per kg per minute. The patient does not respond to verbal or painful stimuli. He is snoring heavily with episodes of apnea and his breath appears to be labored. The patient is possibly oversedated. Thus, you must prioritize to maintain his airway as it requires escalating level of intervention. Consider possible oral airway or nasal airway. The entitled CO2 waveform is now completely flat, and Mr. Jones' oxygen saturation is beginning to drop below 92%. You assess that the patient appears to be mouth breathing. An oral airway is carefully placed, and you switch the patient into a venti mask. Due to continued airway compromise, you administer oxygen provided through bag mask ventilation in order to assist Mr. Jones' ventilation. And the propofol infusion is significantly reduced.
The dose from 150 mics per kilo per minute to 50 mics per
The most important decision making in this scenario is by approaching to relieve airway obstruction and improve ventilation, from nasal cannula to the use of oral or nasal airway, to face mask, and to bag mask ventilation. To recap the key points of this video training, when the level of sedation of the patient is minimal, it is important to recognize when the patient starts to become drowsy, when the patient is finally comfortable, and or when the patient is responsive to verbal and painful stimuli. The appropriate action when the patient is minimally sedated is to balance the patient's comfort level based on surgical requirements. When patient's level of sedation is moderate, it is important to recognize the patient's purposeful response to verbal and or light response to painful stimuli, light snoring, and dampening of entitled CO2. The appropriate action when the patient is moderately sedated is to ask the patient to take a deep breath and perform head tilt and chin lift. And lastly, when the patient's level of sedation is deep, it is important to recognize that the patient will have no response to verbal and or painful stimuli. There will be snoring with episodes of apnea, labored breathing, mouth breathing, and low oxygen saturation. The most appropriate action when the patient is in deep sedation is to provide jaw thrust, possible insertion of oral or nasal airway, consider using face masks such as venti, rebreather, or non-rebreather mask, or even bag mask to assist ventilation. If the following intervention does not immediately improve the patient's oxygenation and ventilation, or you do notice hemodynamic changes, always call for help.
Actually, I don't want to pull any of this stuff off. You guys take it off.
We'll do it.
Good job. Tim will take off the stickers.
Actually, I might not want her to.